Hello, I'm John Gribben from Barts in London. I'm joined by my good friend Stephan Stilgenbauer from the University of Ulm in Germany, and we're here in Orlando at ASH 2015. So Stephan, as always, one of the highlights of the whole meeting again becoming CLL. It's gone from being a Sleepy Valley disease to kind of the disease in which we're able to show the real translation from science through to treatment. So what do you think, what for you have been the highlights of the meeting so far? For me, of course, it's all the presentations that you're doing.
I mean, obviously, for patients and for us as physicians caring for the patients, it is really that we see, biological principles, pathogenic things driving the disease now being not only turned into, prognostic and stratification schedules, but really becoming targets of the disease, or things like, BCL2, BTK, PI3K, prominent molecules in cancer biology becoming druggable in general practice or in clinical trials. And really with these new agents, we achieve results for our patients that are really, far better than anything that we could have hoped for in the past with chemotherapy.
Sure. And you're absolutely right. It's that fact, the fact that the science that went behind understanding the disease that has finally led to the treatment, the bringing the science and the treatment together, which makes this a particularly exciting time for CLL. And of course, looking at it the other way, when we thought that the B-cell receptor signaling pathway and we thought that BCL2 were really important in CLL, it took the drugs to then be able to go in to show how effective it was to prove that our hypothesis about the importance of those pathways was absolutely fundamental to the CLL survival, right?
Exactly. I mean, we're proven actually pretty dumb boys in the lab, because it took really, as you say, these drugs to show how essential apparently these pathways are. Because as with a single agent, very well tolerated treatment, you induce these remissions and achieve these survival times, while in the lab we tried with mouse models or in vitro work to decipher this complex scenario that in the end proved to be, you have a single target, and if you target that efficiently, you achieve great results. Albeit you have to say, as we know, BCL2 targeting has been under investigation for quite a while, and yes, it took quite a bit of an effort to find the right tools to really deliver efficacious therapy.
But in the end, it proved to be worthwhile, because I certainly thought that probably drugs like ABT199 or Venetoclax would be probably chemosensitizers that would work very well with chemotherapy. I think it's come as a great surprise to us that the drug as a single agent is quite so effective in CLL, and in fact probably more effective in CLL than any of the other diseases in which it's being used as a single agent.
Absolutely. I think the development, as you say, was the program under the whole, under the hope that this would sensitize the cells to chemotherapy, and we still need that. However, unfortunately, so it turned out otherwise. Nevertheless, as you say, BCL2 is probably among all malignancies that we look at, despite follicular lymphoma being characterized by this rearrangement, CLL is probably the disease with the highest, or among the highest, absolute BCL2 expressors. So it comes kind of as a natural thing to target that. And on the other hand, coming more to the B-cell receptor signaling antagonists, we know that in CLL at least, oncogenic mutations in the B-cell receptor or other cell surface receptor signaling pathways are not found. So it's not, a oncogenic transformation pathway by genomic abnormalities, but it's kind of a physiological stimulation.
Fundamental process in the CLL
indeed,
cells.
of B cells probably in general, and therefore also of malignant B cells, as which we recognize CLL cells obviously very much.
So thinking again about B-cell receptor signaling inhibitors, so we're seeing more data at this meeting in terms of new trials. So Resonate-2 reporting here. What's your take on moving a drug like ibrutinib earlier and earlier in the treatment of the disease?
Right, so the B-cell receptor signaling antagonists like idelalisib or ibrutinib were obviously, as usual, developed first in trials for patients with heavily pretreated relapsed refractory disease or genetic high-risk features such as 17p deletion. But more and more, already in the pivotal RESONATE trial, it was shown in subgroup analyses that earlier treatment with ibrutinib resulted into better outcome. And at this ASH meeting, we will see the data of the phase 3 RESONATE 2 trial for frontline treatment of patients over the age of 65, randomized comparison ibrutinib against chlorambucil. And I mean, we all expected that this trial will be very positive for ibrutinib.
As indeed it is.
But still, the degree of superiority or the overall survival and progression-free survival times that we see with ibrutinib in this population, in this trial, in historical comparison also to chemoimmunotherapy, look, I would say, at least very promising.
Can we as a society afford all of our CLL patients to go on a therapy for the rest of their lives?
Well, this is obviously a critical question, this word of sustainability. At this year's ASCO meeting already there was a very nice discussion around that topic, as this is not only a problem in CLL, but with similar drugs in diseases like lung cancer, colorectal cancer, you name it. You know, I think this is really clearly a very relevant political, financial dimension. So our aim clearly in further analyses and further trials, further biological analyses also is to develop treatments that will allow us to have finite treatment durations, also for the patients, because these minor side effects like a bit of arthralgia or sometimes headaches or a bit of diarrhea that you can have with these agents in the long run can become very disturbing.
Sure. And a side effect profile that you have for the period of time when you see your disease disappear may be worthwhile to see the lymph nodes shrink. But those same side effects in year 2 and in year 3 and in year 4 can... and the other thing, of course, is a constant reminder of your disease potentially by taking the tablet. However, we shouldn't take away from the fact that these are much more effective treatments than anything we've ever had before. So at this meeting also, of course, we're seeing a lot of so-called second-generation drugs. So, ACP-199 is a novel BTK inhibitor being presented here. What do you make of, and is there room for another BTK inhibitor? Do you see evidence to suggest that this is really second-generation, or is it just more of the same?
Yeah, that's always the relevant question, isn't it? Is it just a me too, or
is it something
just,
better?
Is it really better in providing advance? And I mean, for all the success stories that we've seen, BCL2, PI3K, BTK in particular, there are now these second generations or even third generation developments, as you say. I think some companies have to be applauded for even taking a head-to-head comparison, ibrutinib against a novel BTK inhibitor. The preliminary results, as will be presented here and published very soon, look really that promising that we can say, probably for the benefit of our patients, it looks really like this treatment principle being repeated and possibly even improved with novel developments.
Sure. Now, of course, the other drug approved is idelalisib in CLL, used in combination with rituximab. A little bit more of a slightly higher toxicity profile for the most part with idelalisib probably compared to ibrutinib, but although for some individuals clearly still a very good treatment option. There are, of course, second-generation PI3 kinase inhibitors, so duvelisib, TGR-1202, having data here presented. Do you think there's anything different appearing about those classes of drugs compared to the kind of the father of them, the idelalisib?
All right. I mean, as you say, I mean, it's good to have these different options available. I mean, they're really breakthroughs, even if we find little downsides of one of the agents or the other. Clearly, to have these available for our patients is of enormous benefit. There are these patient profiles. We know that all agents have their different side effect profiles, so it's good that you can select for your individual patient this or that agent. And as you say, the new developments, maybe more specific drugs or isoforms of protein that we inhibit, clearly hold the promise that we can improve on efficacy and tolerability of these agents.
Now, clearly, the next big kind of player in the field is clearly going to be Venetoclax. I mean, you're presenting the data on the data that's probably going to be the registration for this drug, and we're all expecting that very soon this drug will be approved and available for 17p deleted state. So what, we talked a little bit about the science of targeting BCL2, but what excites you about this agent?
Right, so it's clearly, I think to me it's the principle that, I mean, B-cell receptor signaling, yes, has been shown actually with two targets, BTK and PI3K. Yes, this is essential for the cell. Yes, with this in the clinic we can induce remissions, we can prolong patient survival, we can really provide great benefit to the patient. And now we have this other side, totally different target, BCL2, really entirely other side of the cell, if you wish, or a totally different biological principle. And yet again, we show here as a kind of a paradigm that targeting critical disease biology, you know, can lead to great clinical results. Now, specifically to Venetoclax, I mean, I think the thing that is so impressive to all of us is really the speed of response. So as you know, I mean, actually you have to apply quite a bit of vigilance. There's this ramp-up dosing, and you monitor labs very carefully because tumor lysis syndrome, due to this great degree and rapid onset efficacy, can become problematic, and you have to really handle this with care. But if done so, it really delivers great benefit, and this rapidity of response, this depth of remission with a very well tolerated single agent oral therapy is, I think, really impressive to me.
Now, of course, we've talked in two things. We're talking here about single agents, and we're talking about potentially the challenge of paying for those therapies. But of course, what I'm going to get onto next is the issue of the novel combinations. Clearly, if one drug's very expensive, then two drugs are twice as expensive, and three drugs are 3 times as expensive. But the hope would be that by finding the right combination of drugs together, we can get patients onto drugs, get the disease back into a deep enough remission, we can stop the disease, the treatment again. So you'd have the idea that even though you'd have a more expensive 6-period or 8-month period, whatever, defined drug time, you'd get the patients back off the. Is that where you see the field going the way I do?
Absolutely. I think there's several sorts of developments here. As you said, further developments, new compounds targeting the same targets are coming down the road, leading to some sort of competition also with regard to the pricing and the landscape of treatments available. And then, as you say, the combination may indeed lead to finite treatment durations, because you can put the disease into a remission, relieve the patient from his symptoms, and potentially looking forward, I mean, looking at the single agent activity of these compounds, when we combine 1, 2, 3, maybe however many together, I mean, for the first time, possibly there is potentially the hope for even cure of the disease.
So you are in favor of the sorts of trials where you put these drugs in combination, follow minimal residual disease, and look for minimal residual disease eradication as a potential indication for stopping therapy? Or do you think these types of novel agents have made minimal residual disease monitoring obsolete?
Well, I mean, this is an interesting and controversial question. I mean, we know data with ibrutinib, for instance, that the patients who have a longer lymphocytosis in their blood indeed have better outcome. So if you have prolonged lymphocytosis, obviously you are not MRD negative, yet you have better outcome. Now, that principle may revert again when we really combine and try to achieve quickly achieve deep responses. I think yet again the question is still open whether sequencing, smart sequencing, so one after the other of these agents provides in the long term better outcome, or a combination of them all together. But that is certainly a question that we currently at many sites in the world address in clinical trials, if combinations can really lead to finite treatment duration, deep responses, potentially even cure.
Sure. And do you think the era of chemotherapy is almost over?
Well, I think chemotherapy or chemoimmunotherapy, so in CLL, CD20 antibody plus chemotherapy, clearly provided great benefits, was the way forward, is still the standard of care for the average risk frontline patients. I mean, we will see new data at this meeting, ibrutinib versus chlorambucil. Now we can debate about the standard arm chlorambucil without antibody. However, this is the way the trial had to be designed at the time, and the results are that positive that clearly it's a convincing trial. Now, I think more and more, and we are clearly on the way that chemotherapy will, in my opinion, lose its role, at least among patients where you have some doubts, elderly patients, decreased renal function, or in particular the patients with high-risk features such as 17p deletion or TP53 mutation, for whom already today something other than chemotherapy is the standard of care.
Sure. So there you have it. What's clearly exciting both Stephan and I at this meeting is the continued emerging data on the use of novel agents targeting the pathways that are important in the management of CLL, how we optimize which patients we should treat, how we can expand access to more patients to these very powerful agents going forward, clearly revolutionizing the way we think about treating CLL.